I want to thank the organizing committee, especially a colleague and friend, Dr. Carissa Wentland, for the opportunity to present today at the annual clinical assembly and to present a topic that I have learned about a lot over the past few years and really enjoy researching, treating patients with this process, and being able to present my work. I have no disclosures or conflicts of interest. I listed a few sources. Some of these are manuscripts that our group at Rainbow Babies and Children's Hospital published, and others are articles that I'll reference throughout the course of the talk today. Some objectives. I want us to be able to talk through the radiographic findings in patients with EVA, just because that really represents the diagnostic criteria, and then look at other associated inner ear anomalies, especially Mondini malformation or incomplete partition type 2. We'll also talk about the pattern of hearing loss in patients with EVA, because it can be quite unique in the presentation, and then the progression of EVA-related hearing loss. We'll talk a bit about the genetic component of EVA-related hearing loss, although we'll discuss that in not as much detail as some of the other things. And then we'll talk about treatment, but really ends up being rehabilitation plans for patients with EVA as it relates to hearing rehabilitation, but also vestibular symptom rehabilitation. So our topic today is Enlarged Vestibular Aqueduct, and we'll do, as I said, a review of some of the work that we've been able to do at Rainbow Babies and Children's Hospital in Cleveland, and also just a summary of the disease process by introduction, how patients present, the diagnosis and how the diagnosis is made, the clinical course, specifically with regard to the hearing loss and stability, and then, as I mentioned, treatment and rehabilitation. EVA, or enlarged vestibular aqueduct, is typically associated with a sensorineural hearing loss, although there are some reports, and I've seen patients as well, who have a mixed hearing loss in the absence of other middle ear fluid or other middle ear process going on. It's thought that this could be a third window phenomenon. It may be bilateral or unilateral. It may be progressive. Fluctuation of hearing loss is common, and it can be a sign of progression, but also can occur in patients who have stable hearing and may be associated with other ear malformations, as we mentioned. Patients can also present with vertigo, although usually the presentation is with hearing loss, although a good history might elucidate vertigo or balance symptoms as well. Genetics plays a role. There is a specific syndromic EVA component, most commonly Pendred syndrome and branchio-otorenal syndrome, but other syndromes have been associated with EVA-related hearing loss. Mori et al. In 2008 reported a series of 21 children with EVA, and in their cohort, 82% of ears had stable hearing, 18% of ears demonstrated progressive hearing loss. They also did a systematic review, which included 310 ears with a mean follow-up of 4 years, and bilateral EVA-related hearing loss was 6 times more common than unilateral. The male to female ratio was equal. In the systematic review cohort, hearing was stable in 67% and progressive in 33%. Their subgroup analysis demonstrated hearing fluctuations in 50% of the progressive hearing loss group and 34% of the stable ears. Now, about the enlarged vestibular aqueduct itself. The vestibular aqueduct connects the inner ear to the endolymphatic sac. A vestibular aqueduct that is larger than 1 millimeter at the midpoint is considered enlarged, although there are some other criteria that we will discuss a bit later in the talk. The enlarged vestibular aqueduct, or EVA, may be a sign of corresponding enlargement of the endolymphatic duct, which runs through the vestibular aqueduct, and the endolymphatic sac. Abnormalities in these structures contribute to sensorineural hearing loss by a mechanism that isn't really fully understood. The fluids within the endolymphatic duct and sac must remain in careful balance, and any changes, even pressure changes or content changes, however subtle, can precipitate a hearing loss. It's also why EVA patients can present even with small head trauma events with a significant drop in their hearing acutely. I wanted to go through just a patient presentation of my patient who actually prompted the formation of the patient registry and really, I think, got me most interested in the EVA related hearing loss as a research topic and as a patient interest. So my patient was 5 years old and presented for a clinic visit actually for tonsil issues, and interestingly never needed to go on to have a tonsillectomy. But a review of symptoms and the review of systems paperwork noted that she had recently failed a hearing screen both at school and at her pediatrician's office. So I sent her for an audiogram on the initial clinic visit, which showed a unilateral mild to moderate sensorineural hearing loss. The rest of her exam showed a normal ear exam. She had no balance complaints and no balance issues on the exam. She also, her tonsils were enlarged, but as I mentioned, did not need to be removed. I sent her for imaging. In her case, she got an MRI, which confirmed a unilateral enlargement of the vestibular aqueduct. It was 1.6 millimeters at the midpoint. She has had repeat audiograms, initially at 3 months for a year, and then 6-month intervals for 2 years, and now she has had yearly audiograms. And there has been also hearing aid visits. She was fit for her initial hearing aid shortly after her diagnosis, and then has had other mold fittings and other audiology visits in the meantime. Throughout the whole process, her parents really had excellent clinical questions. They wanted to know about hearing loss progression, possible precipitating factors, activities to avoid, among other things. With their generous donations and crowdsourcing, we used this as the impetus to establish a website through Rainbow Babies, a patient registry, and also hire an EVA-specific research coordinator. And that is what prompted the specific interest in EVA-related hearing loss, especially as it relates to progression of the hearing and fluctuation, as well as documenting any inciting events that may have precipitated the hearing progression. So in general, the enlarged vestibular aqueduct is, as we said, a sensorineural hearing loss, most often confirmed by audiogram, but in certain cases by ABR, depending on the patient cooperation or the ability of the audiologist to capture the information necessary. So sometimes it ends up being sedated ABR in the operating room. Diagnosis is also confirmed by imaging, and have this image that shows enlargement of the vestibular aqueduct here on the CAT scan, and then here on the MRI. When there's an abnormality noted on imaging, it's going to be EVA 5 to 15% of the time. And then we mentioned my specific patient and her hearing outcomes and the size of her vestibular aqueduct. We also sent her for genetics testing, and she was negative for Pendred syndrome. She also has 2 younger brothers, and they were also had audiograms performed and have had serial audiograms since then, and their hearing remains normal. EVA-related hearing loss has an uncertain prognosis. The percentage of patients who have hearing loss or have progression is so far unknown. The hearing loss can also fluctuate, and one of the clinical questions was, does it fluctuate more often in patients who have progression of hearing loss or that have stable hearing loss? Also, the triggers for hearing loss. There have been case reports or case series about sudden sensorineural hearing loss in patients with head trauma or barotrauma. Treatment-wise, really we're left with just hearing amplification, either hearing aids or cochlear implants, depending on the severity of the hearing loss. Sometimes balance testing and, if necessary, vestibular rehabilitation can be employed. But really, there are not really any medical or surgical options to treat EVA. There has been work in animal models for endolymphatic sac abnormalities, but nothing for EVA specifically. So the first clinical question that we had was, regardless of the timing of the presentation, does the size of the vestibular aqueduct correspond to the severity of the hearing loss? So this is a CT scan, temporal bone, measuring midpoint width here. This is the way to determine the midpoint. And our clinical question was, does the size of the vestibular aqueduct correspond with the degree or progression of hearing loss? And we looked at 52 patients with a diagnosis of hearing loss and the radiologic diagnosis of EVA. We used the Valvasori criteria. We looked at speech reception threshold, word recognition score data, and then created mixed effects models where vestibular aqueduct size, the age at diagnosis of hearing loss, and the time since the diagnosis of hearing loss, and tried to predict repeated measures of hearing ability. We noted that the larger the vestibular aqueduct, the worse the higher the speech reception threshold. And similarly, the larger the vestibular aqueduct, the worse word recognition scores. Such that we noted that for each extra year after a patient's first audiogram, there was an increase of 1.5 decibels in speech recognition threshold and a decrease of 1.7% in word recognition scores. But most importantly, each millimeter increase in the vestibular aqueduct size above 1.5 millimeters was associated with an increase of 17.5 decibels in speech reception threshold and a decrease of 21% in word recognition scores. So there was a significant relationship between larger size of vestibular aqueduct compared to worse hearing outcomes, which we thought provided opportunities for counseling patients about the possibility of progression and severity. The next clinical question was what might be the contribution from an incomplete partition type 2 in addition to the enlargement of the vestibular aqueduct. We did a retrospective review of the radiology images. In this case, we measured the midpoint width and the operculum width, and patients meeting the Cincinnati criteria for EVA were selected. And we used still the linear mixed models of hearing test results for all available tests that were constructed, and noted that there were no statistically significant differences in any hearing test results or vestibular aqueduct midpoint and operculum widths. So the hearing loss due to enlarged vestibular aqueduct, we felt, did not appear to be affected by the presence of incomplete partition type 2. And we thought that the results suggested that the pathophysiological processes underlying the hearing loss in EVA may not be a result of cochlear malformation, but perhaps more likely to involve the vestibular aqueduct itself, perhaps the fluid mechanics, or cellular and molecular level mechanisms of hearing loss. Next, we noted that clinically there seemed to be differences between patients who had unilateral and bilateral vestibular aqueducts and the hearing loss associated with it. There were cases where, reported in the literature, where unilateral EVA hearing loss patients began to develop hearing loss in the, quote, good ear. And we wanted to see, to investigate the differences in hearing between patients with unilateral and bilateral enlarged vestibular aqueduct. Our hypothesis was that hearing loss in unilateral EVA would be similar to that seen in bilateral EVA. So we used 3 measures of hearing for this study: the pure tone average, word recognition score, and the speech awareness threshold, and then used the same radiologic morphology and measurements, and then the linear mixed effects models, which we felt was the best way to accurately represent and present the audiometric data. So we used the Cincinnati criteria. We had 89 ears that fit the criteria, and 75 were from patients who had bilateral EVA and 14 from unilateral EVA. We noticed no statistical difference in vestibular aqueduct width or operculum size, and also no statistically significant difference in hearing ability with respect to bilateral EVA versus unilateral EVA. So the fact that patients had unilateral EVA did not mean that their hearing outcomes would be any worse. Also, the fluctuation in hearing. This is so far unpublished data, although we're still in the midst of preparing this for publication. We looked at a retrospective longitudinal repeated measures study design. We used the Cincinnati criteria for EVA and looked at only the unaided ears examined. The patient population was then divided into two subpopulations, patients with fluctuating and non-fluctuating hearing loss. The fluctuation was defined in our study utilizing Madden et al. In 2003 methods and included either one, an interim audiogram showing 10 decibel change in any 3 frequencies, 2, a 15 decibel change in any 2 frequencies, or 3, greater than 20 decibels change at any 1 frequency. And then fluctuation data was collected for each of the following frequencies: 250, 500, 1000, 2000, and 4000 hertz. Patients were also subcategorized depending on whether their clinical course followed progressive or stable hearing loss patterns. And progressive hearing loss was defined as patients with fluctuations in hearing leading to a diminished hearing acuity that never returned to baseline, while stable referred to hearing that either improved over time or stayed at baseline. And the figure shows the distribution of hearing loss patterns of the EVA cohort. Each ear's classification was based on their most recent pure tone average. Patients were divided into subpopulations based on the pattern of hearing loss, either progressive with fluctuation, progressive without fluctuation, stable with fluctuation, and stable without fluctuation. We also had questions about what percentage of patients with EVA presented with vertigo as either a presenting symptom or at some point in their clinical course. And we felt that the best way to help answer that question was to work on a systematic review. This is in the process of being reviewed right now. The manuscript is under review. Of 808 identified studies, 20 met our inclusion criteria, which included needed to have more than 10 patients and have mentioned vertigo or balance issues in their abstract or manuscript. Subjective vestibular symptoms included dizziness, episodic vertigo, and imbalance. 17 of those studies reported subjective vestibular symptoms, but noticed the range from 2 to 71% of patients between studies. 17 studies performed some form of vestibular function test, including physical exam maneuvers, calorics, ENG, VEMPs. Of those who had vestibular function testing, again the range, 7 to 92% had an abnormal result. 2 studies identified head trauma as a risk factor. 1 study successfully treated patients with BPPV using the Epley maneuver, but other vestibular symptoms were not targeted for any specific treatment. So diagnosis, as we mentioned, is really by imaging because in order to determine if the vestibular aqueduct is enlarged, it's a specific CT or MRI measurement. The Valvasori criteria was described in 1978 and was described as a midpoint larger than 1.5 millimeters. And then more recently, and how we've employed it more recently as well, the Cincinnati criteria called for measurements that have a midpoint larger than 0.9 millimeters or a perculum larger than 1.9 millimeters were considered enlarged. Dewan et al. Studied 130 cochlear implant patients and measured the midpoint and the operculum on CT. And they identified of that group of 130 cochlear implant patients, 44% of EVA patients with the Cincinnati criteria and only 16% with the Valvasori criteria. And that the Cincinnati criteria identified 70 ears that were normal by the Valvasori criteria. So our next clinical question was, all of the previous work and diagnostic criteria have utilized linear measurements, either the operculum, the midpoint, or both. But we're looking at a structure that is a three-dimensional structure. So our thought was, why not utilize a volumetric or three-dimensional measure? And does the volumetric measure correlate to hearing loss severity? And is it perhaps more sensitive as a measure than the linear criteria measurement? So this is the way that we took to measuring the volumes with a specific computer algorithm employed by our radiologist. And then this is a video of how the specific vestibular aqueduct three-dimensional measurements were calculated. That work is still ongoing, and but so far it is highly correlated with the linear measurements and with the hearing loss. Now, the genetics components of the diagnosis. There are several genes, but the three main ones are SLC26A4, KCNJ10, and FOXI1. The one that was initially described was SLC26A4 mutation. May et al. Noted that it was biallelic in 70% of one cohort. Invariably, that they had poorer hearing if they were biallelic, and can be associated with the Mondini, EVA, and an enlarged endolymphatic sac. Liu et al. Found 16 variants in 21 different probands. And then KCNJ10 and FOXI1 also are known EVA-related genes. And they're noted in bilateral EVA. And then Jonard et al. Noted that the genes are not major determinants in unilateral deafness and enlarged vestibular aqueduct, that it really is a bilateral EVA issue. The clinical course can be variable. There can be fluctuations of hearing loss, as we discussed, progression of hearing loss, and certain activities to avoid. There was a good systematic review of EVA patients performed by Alemi and Chan that showed 40% of EVA patients had progressive hearing loss, trauma-associated progression in 12% of those patients, but no difference was noted in the incidence of progression between patients with and without head trauma. As we mentioned, there's not really been definitive treatment. Steroids have been shown to recover hearing in anecdotal cases, and in my experience in my clinic, I have had patients who recovered hearing back to baseline by administering a steroid course. I would usually start with oral steroids, but intratympanic steroid injections can be helpful as well. One study that specifically highlights this is Grimmer et al., who reported 80% of patients with hearing loss improved with steroids and 14.3% improved without steroids or with the placebo. Rehabilitation depends on the degree of hearing loss. As we said, hearing amplification is key, and either hearing aids and specifically an FM system, making sure that the school has the resources that they need to support the patient with regard to their hearing amplification needs. And then profound hearing loss would prompt workup for cochlear implant placement. As we noted, that there are patients who present with or have vestibular symptoms as part of their process, and that additional workup is required, and vestibular rehabilitation specifically for patients with vertigo or balance abnormalities. There was one additional study that looked at the benefit of cochlear implant in patients who have enlargement of the vestibular aqueduct. And patients with EVA receiving a cochlear implant can expect an improvement, significant improvement in their pure tone average by 64 decibels, improvement in their speech reception threshold by nearly 58 decibels, and improvement in their word discrim scores by almost 35% based on multivariable analysis. We also found that in patients who have both EVA and incomplete partition type 2, there may be a decreased benefit of cochlear implant with regards to especially the word discrimination scores, although that still requires additional work or additional research in that area. This is the website for our EVA project, which includes a specific website, access to the patient registry where patients can, in a protected way, enter their information. It has educational materials that we've collated regarding EVA that is patient-facing, the annotated literature, and then there's a way to request specific consultation.